Welcome. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. The upcoming conversation is part of our broader series under the auspices of the Value and Access Collaborative that is examining how we can improve the process by which we move from cardiovascular risk screening to meaningful treatment and, most importantly, improved cardiovascular outcomes. I'm excited to be joined today by an eminent preventive cardiologist and a person who is also a cardiology patient. Dr. David Maron is the C.F. Rehnborg Professor of Medicine and Chief of the Stanford Prevention Research Center at Stanford University. His research is focused on the primary and secondary prevention of coronary artery disease. He sees patients in the Stanford Preventive Cardiology Clinic, and Dr. Maron is president-elect of the National Forum's valued member and partner, the American Society for Preventive Cardiology. He is an innovator in managing cardiovascular risk factors, and for that, he was the recipient of the 2025 National Forum Chairs Recognition Award. I'm also excited to have Mr. Doug Sousa here to share his experience and provide a patient's perspective on this important issue. Doug, would you please start us off by telling a little bit about yourself and how you began working with Dr. Maron?
Yes, I was introduced to endocrinologist through my patient through having a cancer, tonsil cancer, and this endocrinologist has seen me for thyroid treatment after my cancer treatments. She's been watching my cholesterol levels, and at that point, watching him climb a little bit, she decided to refer me to a cardiologist, and this treatment was done at Stanford. And my endocrinologist at Stanford and my cardiologist there as well. So that was the first individual to really watch and my cholesterol levels and make a recommendation to go to visit a cardiologist.
Great. Well, first, congratulations on being a cancer survivor. It's very significant, and we appreciate that background, and you're telling us how you came to be a patient of a cardiologist. So, what did your endocrinologist identify as cardiovascular risk? I mean, what prompted the endocrinologist to say, Doug, you need to see a cardiologist?
It was mainly my cholesterol levels and observing them over a series of about 4 or 5 years.
Okay. Okay.
And
And you're you're a cancer survivor. You've gone through the treatment for that. They're keeping a close eye on you after treatment, during treatment, and then you have this information about, oh, your cholesterol is high too. What was that like? I mean, how did that feel, Doug, to have that additional cardiovascular risk factor added to concerns you already were dealing with?
um, well, that wasn't a pure shock. Probably the biggest shock was because you know about you're informed. If you're informed, and watching your health, that cholesterol is an important factor to be monitoring, which I have been. But probably the biggest impact was my first visit to a cardiologist, which I was informed that I had severe calcification, CAC, and that was me being informed years after a scan for a follow-up scan for my cancer. So I was not informed that I had calcification. And initially, it was not in my records. It was not told to me at that time. So this was over 4 years later that I'm learning that I have severe CAC. And that was probably the biggest shock and surprise because I hadn't been informed. So at that time. So that's what really prompted my relationship with Dr. Maron, because at that point, I was invited to participate as a patient representative in his group doing many different studies.
So, Dr. Maron, here comes Doug Sousa. He's been referred to you. How do you approach conversations with Doug and other patients about cardiovascular risk and then adhering to the treatment regimen that you agree on?
So, Doug, as I recall, you you knew about your high cholesterol, but you were not taking medication for lowering it. Is that right?
That's correct.
And and so I think that that is really, can you remember why you had decided not to take medication for lowering your
Yes.
cholesterol?
So I have to admit, my primary care was monitoring and watching.
Yeah.
At that time, my primary care was probably a person seeing 150 people a day. So his attention to these kinds of things was there. I thought he was a very good doctor, but he was watching my cholesterol. And this is years before I started any treatments. He said, smart people would take this medication, and he hands me a prescription for a statin. Well, that wasn't enough for me, enough information. It wasn't enough guidance to tell me and convince me that I should be on lower lipid, medication. On top of the fact that my rep, my understanding of statins that it had, could cause liver damage. So that was also an item that was not explained very well to me in no conversation, essentially, from my primary care. Once I got connected with Dr. Maron, he explained to me that that's no longer a factor. So I think in this conversation, what's very important is I think that myth is very much still out there. And I think that would make a huge change in people adopting medication for their lipid lowering medication. So for me, I needed to have a stronger conversation, a more informed conversation about the risks and the benefits, of course.
So if I had I would have guessed that it wasn't that what really made a difference was seeing that you had this calcified plaque in your coronary arteries, having it explained to you. And I think that we looked at the images together. And what was your response to that?
Well, that obviously was very concerning, just because I understand that my father had a history of a five-way, six-way bypass when he was in his early 50s, and I knew what that was about as far as plaque and calcification. So, of course, the name calcification was new. I understood it as plaque, but it's virtually the same. So yeah, that was very concerning, and it wasn't just mild, it wasn't low, it was severe. So that was, an eye opening, and 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 it was explained to me thoroughly by a nurse practitioner that the mechanism in which a statin works, and that made perfect sense, and that was an easy decision. It was an immediate decision that I would start on a statin.
So John, in response to your question, how do I, how do I approach a patient? Um, I use imaging a lot because I think that being able to see one's own atherosclerosis, the deposits in their arteries, is much more compelling than telling them they have high cholesterol or showing them a number. It's seeing an image of one's own disease process really captures a person's attention and motivates them to take action to protect themselves. So instead of going from the abstract, your risk is X percent over the next 10 years or 30 years, um, when one is confronted with the knowledge and the being able to see their own condition, it changes everything.
Yeah. Well, that resonates with me. I'm a visual learner and big believer in data, but yeah, those images are, as you just said, Dr. Maron, very compelling. So, Doug, you saw the images, you saw your own arteries. Was that compelling for you?
Yeah, absolutely. Yeah.
And I heard you, both of you, but particularly the way you sort of set the stage, Doug. I heard you talking about the importance of the conversation that you had. So it wasn't just the information that you received, but the way in which it was imparted. I mean, it sounds to me like a textbook example of shared decision making. Um,
Yeah, I would agree. And I think the way it's delivered, in my story, you heard that I had a delivery from a person who was not giving me a lot of information, just saying if you were smart, you would do this, and that's not enough. And then you have somebody else who's following you and giving a good explanation about, okay, now it's time you should take the next step and see a cardiologist. So yeah, it's in steps. And then as I got to the cardiology group, that was a more clear explanation. I think how the message is delivered, everybody's going to receive information differently. But if you can tailor it and understand, and that's what physicians do every day, is looking at their patient going, this person I know and will understand if I present it this way. And they need to present it differently, probably for different people. And that's going to be complicated, but I think that's really important.
Yeah, absolutely. Dr. Marin, I did not say in introducing you that you, in addition to the many things that you do, the many hats that you wear, you are a leader in the California Right Care Initiative. And I know the Right Care Initiative and the systems that are part of it have done really exemplary work in terms of implementing evidence-based practices that have improved the health of the people they serve. And one of those practices is shared decision making, is it not?
It sure is. One of the most frustrating things for me as a preventive cardiologist is for decades, we have known how to prevent heart disease. And yes, we do research and we're learning new things all the time. But if we would just implement what we already know, we could be saving so many lives. And part of that implementation is understanding how to convey information to patients. And shared decision making, what it really means from my perspective, is making sure that the patient that I'm with understands what the risk is for themselves and what their options are for treatment and understanding what their goals are. What concerns them? What are their goals in life? What motivates them to um, in their daily lives? And finding that connection with the patient, understanding them and making sure they understand what they are facing, help them make a decision that makes sense for them. And usually the decision is a sensible one. And as in Doug's case, he made a good decision to get on appropriate therapy and understands what for example, the LDL cholesterol goal is. And uh, from what I can tell, he's doing a great job taking care of himself with the guidance I've provided.
I'm really intrigued by some of the wording you just used, Dr. Maron. Doug made a good decision. Doug, from your side of the exam room, does it feel to you like you made a good decision about what course to follow to treat your high cholesterol?
Yes, absolutely.
And did the shared decision-making process affect your buy-in on the choice that you made?
I, I, I think once everything was explained properly, and I felt like I got all the information, that was pretty easy decision to, pursue what was recommended as treatments. So again, it's back to the message, and how it's delivered.
Yeah. So when did Dr. Marin prescribe your LDLC treatment?
Yeah, it was that very first meeting, essentially,
Which was
when,
when?
which was when I discovered that I had calcification, and that and then family history, everything was brought
Right.
forward at that point, and you recognize, yeah, this is the proper way. At least that's how I felt about it.
Yeah.
That was proper for me to pursue it,
And how
including
recent was that?
that was 7, 8 years ago now.
Okay, so I'm
Maybe one
really
more
interested.
point.
Yeah,
Sorry to
please,
interrupt.
please.
One more point. Speaking of shared, it's also your spouse is part of that decision. In my case,
That
that
is,
it's a conversation between the two of us looking at each other during that meeting, because she was with me. We were both surprised by, the results of scan that I had years earlier. And yeah, we're both left there and on the drive home going, yeah, this is what needs to be done.
I'm really glad you added that. Very important, the role of family members, caregivers, in helping you make the decision and then stick with it. And David, you know these numbers better than I do. I think it's a majority of people who begin treatment for high LDL cholesterol within a year, half of them roughly have discontinued treatment. Is that right?
Yep, that's right.
Yeah, so Doug, you're the exception, and you're sort of our model in the fact that you've stuck with it. So I'm really interested. What has caused you to stick with it, and are there things about the care that you have received and are receiving from Dr. Maron and his colleagues that have factored into your sticking with that treatment?
I think, well, hitting objectives, lowering the cholesterol level to what's recommended. That obviously is an indication that things are working. And that's what your goal was when you had the first meeting with a cardiologist. You have your objectives, and that's what's kept me going. I'm in my view of my life, I think that's the thing that's going to keep me healthy for the longest is staying on this program. I can't understand why other people, they have outside influences, maybe things like that, that gets them to change their mind about staying on a
Yeah.
regimen of care.
Well, some people, I know they hit their goal and they think, okay, I've done it, so now I can stop. And often that, or maybe always, that's without consulting their physician or their clinician. Um, you haven't done that. So what, if anything, is it because you were smarter or, and I'm willing to buy that if that's the case, or is it because you're part of a feedback loop and part of your ongoing care is receiving information that helped you understand the importance of sticking with the treatment?
I think getting new information, just had, you know, a conversation with my nurse practitioner at Stanford, and there was a new piece of information I received, and I was going, "Oh, okay, there's even a new and additional benefit from staying on my program."
Yeah. Um, so Dr. Maron, you're, in addition to being a practitioner and a leader at Stanford, you're a leader on a national basis. Uh, so from your vantage point, is shared decision making used universally throughout the US healthcare system? Does everybody benefit from it?
I think everybody that has the opportunity to share in decision-making benefits, um, it is, I really can't speak to how often uh, this practice is practiced. I don't know how often shared decision-making takes place in an exam room. The primary care physician has so little time to interact with patients. And if this isn't an annual preventive oriented appointment, boy, I just think that the challenge is so great for a primary care physician to have the time they'll to really have a meaningful conversation with patients. It's just so difficult. Um, you probably know more than I do about if there have been any surveys about the use of shared decision making, but my guess is it doesn't happen that much.
And you'd be right. So have do you know of or have in mind any kinds of systems changes that would enable more clinicians, more practices to provide shared decision making for their patients?
Well, I think that uh, it it requires having a workforce that is well trained, and I'm talking about an extension of the physician. Um, Doug met with a nurse practitioner, I think, before I ever met him the first time. Nurse practitioners, physician assistants, pharmacists, dietitians, genetic counselors is another
Yep,
profession that we
yep,
work with.
yep.
It's a healthcare team to sort of share the uh, the responsibility and the time and really, frankly, to offload the tremendous burden, the tremendous pressure that the primary care physician has. Um, I work in an ivory tower. I have a 1 hour time slot for a new patient and 30 minutes for a follow-up patient. That's not a sustainable model across the U.S. Um, and even with that, well, I think with that, I do have enough time to accomplish what I want to, but I've got a backlog of people waiting to be seen. I think that having someone to hand off after the initial visit with me would be a more efficient way to practice.
So I think what you're describing is commonly called team-based care. And again, something that is promoted and widely practiced by the systems and institutions that are part of the Right Care initiative. And it works. The evidence is so strong showing that. And I noticed, Doug, in your comments as you were telling your story very early on, you talked about the important role that the nurse practitioner played. Um, who are the different members of the team with whom you have interacted?
Primarily with the nurse practitioner at this stage. We have a now 7-year relationship, let's put it that way. And it's only annual, but it's also questions in between that she responds very quickly. And so I think once you're on a path and you're confident of that and everything, the numbers still look good. There's probably, in my case, I don't feel the need to have a every 4-month visit with Dr. Maron directly. That's for sure. He is my cardiologist. So and I feel fortunate on the subject of primary care that I have my wife and I have the same primary care, and she's excellent. She's well informed and she's practical. I mean, she's not forcing or suggesting crazy things that she knows is not, something that a regimen and diet or something that a person can't stay on. So that
Mhm.
I feel very fortunate there to have that locally.
Yeah, that having a good primary care clinician is so important, so valuable. Dr. Marin, you have the luxury of being able to spend ample time with the patients you serve. How does practicing team-based care enable you to help more patients than you would if you in the absence of team-based care?
Well, for prevention, nutrition is such an important component of good care, and being able to hand off a patient to a dietitian for nutritional counseling, for whether it's for cholesterol lowering, lowering blood pressure, weight loss, and those are the usual reasons, lowering triglycerides, controlling blood sugar. That's a great benefit to me. I can just emphasize the importance and make the referral. So that's one thing. And then for patients that have severe hypercholesterolemia, really high cholesterol, in whom I suspect they may have familial hypercholesterolemia, being able to refer to a genetic counselor it's a luxury for me. I know that that's not available to all practices, but that also helps with the follow-up conversations that are
Hmm.
necessary. Um, Being able to refer, and this is going a little bit beyond primary prevention, but being able to refer to cardiac rehabilitation for patients with established heart disease is they are my eyes on the ground and really
Yep,
help with secondary prevention.
yep, yep. And I'm so glad that you mentioned that because this is another area where the evidence is so abundant. Cardiac rehab works. Cardiac rehab makes a huge difference in a patient's probability of success, of having good outcomes. And yet, only 25% of people for whom cardiac rehab is appropriate are referred. So, how do we change that, David Marin?
You know, we have an automatic system where everyone in the hospital after a heart attack or after bypass surgery or after stenting automatically get a visit with the in-hospital cardiac rehab person and a referral. But not everybody who's referred shows up. And how do we do that? You're asking about implementation. We know that cardiac rehab works. It saves lives. It's one of the most effective interventions that we have. And
Indeed.
where our research needs to focus is on implementation. How do we translate what we know into practice? And I wish I had the answer for you. But again, it's communicating with patients about the importance of the knowledge that we already have of that this works.
Yeah. Yeah. So a couple of quick things. One, I want to just point out that what you just said about the difference that cardiac rehab makes in outcomes in saving lives, that's not your opinion. It's not your judgment. Those are facts, right?
Right.
Yeah. So you mentioned, Dr. Maron, that you have, I'm paraphrasing here, what triggers built into your system to trigger referrals to cardiac rehab. Is that,
Correct.
did I understand that correctly?
That's correct.
So
So
how does
that's
that work? Is that in the EHR or
it's in
what's
the
that look like?
electronic health record, and order gets generated and it needs to be signed by the referring physician.
Okay.
So, yeah.
Okay. So it can be baked into the system you're using,
Mhm.
and that lifts the practitioner's ability to deliver that evidence-based care. Is that a fair way to paraphrase?
It's fair. It reminds the physician, and they would basically have to opt out so that there's an automatic referral.
Hmm.
But as I said, patient doesn't always show up, and that's reflected in the statistic that you cited earlier.
So
So does shared decision making make a difference, or could it make a difference
Absolutely.
in? Okay.
Yeah. Just explaining that this is as important or more important than prescribing a medication. This is a, it's an education. It's something that with um, group support from other people going through the same experience, it's learning how to um, learning the safety, reassurance of being physically active. But it's more than just the physical activity that takes place in cardiac rehab. It's multifactorial, it's educational about side effects from medicines, the importance of of controlling blood pressure, what's the blood pressure goal, what's the cholesterol goal, what's the blood sugar goal. Um, it's multi-component and highly effective because ultimately what really makes a difference in survival in people with or at high risk of heart disease is controlling their risk factors. It's really actually not
Hmm.
having procedures, at least in the case of a patient who's not having a heart attack.
Yeah. Yeah.
I have a
Uh,
question. I have a question about the people opting out of this treatment. Are they this have the same mentality, the people that don't take their medication after a year's time or 6 months' time?
It's part of the same phenomenon, right? I don't have the time. I don't want to be bothered. I'd like to do this on my own. Um, it's I think it's a lack of understanding um, colliding with personality. And ultimately, I do think that the connection with the clinician makes all the difference in terms of people following through.
Do you think an education level makes a difference?
Yes, unfortunately, it does.
But not in all
So,
cases. I said
so
not in all cases.
Um, no, I mean every individual is different. Um, More highly educated um, patients are more likely to follow the recommendations, either because of access, financial resources, or understanding the importance. There are a lot of variables that go into it, but um, level of education, um, socioeconomic status is a variable that has an impact on prognosis, and it has to do with following um, guideline-based care.
So
can can shared decision making bend the curve there? Can shared decision making help to narrow or eliminate those gaps along socioeconomic status uh, factors?
For sure, it can help narrow the gap. It's not the um, it isn't the only answer, but it's so important to make sure that the patient understands their options and what the risks are from not following the advice.
Yeah, Doug, I really appreciate your questions. I should have put you in my seat, and I think would have made for an even better conversation. This is a terrific conversation. I would love to continue for another half hour with both of you. It's just really illuminating, but unfortunately, we're coming up on the close of the time that we have together today. So I want to ask just a couple of questions in closing. Doug, you're successful in, you said you reached your goal, and I don't think you said it explicitly, but I think I heard in your comments that you've been able to maintain that success at goal. Is that right?
that's correct so far.
And how has the approach that Dr. Maron's clinic, that the Stanford Prevention Research Center uses, that includes shared decision making and team-based care, entered into that? How has that been a factor, if at all, in your successful journey as a patient?
Yeah, I mean it is the difference. It's that communication and keeping me informed about anything new that's come along. And yeah, that's made the difference in me staying on track and trying to increase my exercise levels and things like that. I get a little push from the nurse practitioner all the time, so I'm trying to always adjust that as well to help the whole process of staying healthy.
Yeah. And David Maron, if you could be the head of the health system for a day, what change would you make so that more people in the United States, throughout the United States, could benefit from team-based care and from shared decision making?
Thank you for asking me that
and
question.
cardiac rehab.
Yeah. Um, what I would do if I had the power is I would take people of a certain age and offer them for free a coronary artery calcium scan because our risk assessment tools are not as good as imaging of the coronary arteries with this inexpensive, non-invasive test to identify people who have the disease process, atherosclerosis, growing. And then if they have the coronary calcium, as the head of the health system, I would make sure that the patient is notified, the clinician is notified, they communicate with each other and engage in shared decision making about getting started with effective preventive interventions so we can prevent all the unnecessary heart attacks and deaths that occur every day. So that's what I would do.
That's a fantastic note to close on. This has been a great conversation. Doug Sousa, David Maron, I really appreciate your joining us and sharing your insights. Doug, thank you for sharing your personal experience. It's been very valuable. And the National Forum for Heart Disease and Stroke Prevention is grateful to you for your time and, as I said, sharing your insights.
You're welcome.
Thanks for the opportunity.